last roundtable, we had a discussion about pre-implantation genetic testing for aneuploidy. And we described the process by which the biopsies are performed. And then we talked briefly about some of the philosophy behind it. So maybe, Carol, you could remind us a little about trophectoderm biopsy and what actually happens during a trophectoderm biopsy.
Okay, well, during the trophectoderm biopsy, when the embryo is at the blastocyst stage, a hole is made in the zona where then the embryo will herniate out and will remove some of the cells from the trophectoderm and send those for biopsy analysis. In that process, there's always a chance that that embryo could be damaged. You're not removing cells from the inner cell mass, which becomes the baby, but you are removing them from the trophectoderm, which becomes the placenta.
So Dr. Keenan, when patients undergo this procedure, I think in their mind, they're thinking a definitive diagnosis is going to be made. They're going to be told up or down, and it's going to be absolutely clear-cut, and then they can make a decision without any second thoughts whatsoever. Is that really the case, and why is it perhaps an issue?
Yeah, no, it's definitely not the case. And so the biopsy results will come back as either euploid, which means a normal number of chromosomes, 46XX for female, 46XY for male, or aneuploid, which is anything other than 46XX and 46YY if it's consistent through all 3 or 4, 5, 6 cells that they biopsy. But unfortunately, there are a number of embryos that come back as what we call mosaic. That is, it appears that they have a mixture of normal or euploid cells with 46 chromosomes, and then some cells with maybe 45, maybe 47, maybe triploidy, different things that you could have that are mixed in together. And so that's what we call a mosaic embryo, and that's, I guess, one of the bigger causes for concern.
So recently, Dr. Foreman and Dr. Paulson, who are two leaders in the field of infertility, in particular interest in PGTA, had a round table. And Dr. Foreman's contention was maybe these mosaics are not truly mosaics. And this is really an assay issue in terms of the abnormal copy count being amplified. Because in nature, Carol, I mean, do we see this? I mean, do we actually see mosaic individuals? Do we see mosaic embryos in terms of, or when we have patients who have had miscarriages?
We don't actually see mosaics. You either have a child or you don't have a child. And without doing, having, you know, the whatever they've lost, the fetus, without being able to look at the fetus and try and determine that, you don't know.
But Dr. Keenan, these are pretty uncommon. When we look at DNC specimens, if mosaicism really was incredibly prevalent in reproduction, as much as it seems to be when we look at the PGT results, wouldn't we see more than when we do the DNCs and do karyotyping?
Right. It's incredibly rare that we look at miscarriage, products of conception, and find mosaicism. You can find that sometimes, but it's very uncommon, as opposed to mosaic results from an embryo biopsy, which are relatively common.
So now we have a challenge then, right? So we have these results. So how should we counsel our patients? So Dr. Keenan, what do you think what should we tell them? And what are our challenges that we face as professionals when we've sort of painted ourselves in the corner? We said, here, we've got this great technique. It's going to give you thumbs up or thumbs down. And all of a sudden, there's this gray area. So what do we do?
Yeah, I think there are a couple of considerations from the patient's perspective and from the physician's perspective. The most significant concern from the physician's perspective is medical legal. And what if I transfer these mosaic embryos and this child doesn't turn out right in any way, or the couple is going to come back and sue me? And so for that reason, most clinicians are really reluctant to transfer mosaic embryos. It's also a very emotional aspect for the patients, because they think, well, is this normal or not normal? And what if I only have mosaic embryos? Or what if I use my normal quote unquote embryos, have a baby or not, and then should I use these, and all the anxiety that can provoke in these couples. So yes, it's a really very difficult situation for them.
So what happens, Carol, in a situation if a clinic says you can't transfer that embryo and the patient wants to do the transfer?
Again, there's the medical legal side of this, and you need to find a clinic that would be willing to do that. But there was a major study done up in New England where they did transfer mosaic embryos and had very good results. So, again, it's a challenge for us as medical professionals. Will we at this time be allowed the transfer of these embryos? And I don't think it's any higher than if you transfer embryos that haven't undergone pre-implantation genetic testing using these embryos.
Except now they're told they can't use them.
Right.
So they say, if I could turn back the clock to 2 weeks ago, I would have told you don't do the biopsy because now you're holding my embryos hostage and you won't let me do the transfer. Right. And and as you know, for all the years you've been doing it, that you just can't tell. You don't know what's going to implant. The only way that you know it won't implant is if you never transfer it.
Yeah, that's the only way.
Then you know it will absolutely not implant. So Dr. Keenan, as the medical director of the NEDC, what is the NEDC's approach to patients who may want to donate mosaic embryos or patients who may be interested in adopting? And what advice can you give any individual who is facing this decision, embryo adoption, or with your own desire to conceive? What would you tell them?
Well, I would just reiterate what we just said, that before we tested embryos, if there really are a considerable number of embryos that are mosaic, before PGT, we were transferring them all the time on a regular and routine basis, and we've never have seen a significantly increased risk of chromosomal abnormalities with IVF, or embryos fertilized in the lab. And so I would tell them, transfer these embryos. And as far as the NEDC, we are in an enviable position in some ways in that we have many, many couples that want to transfer their embryos to us. In fact, so many that we really don't have enough storage space for all the embryos that we could potentially get. So for that reason, and because still many couples are reluctant to have mosaic embryos transferred, we do not accept mosaic embryos for transfer unless a couple specifically requests that. Then we're very glad or happy to do it, just like we will accept trisomy embryos to transfer if a patient requests that.
These are difficult decisions for patients to make, and I think that sometimes they look at it superficially, they expect one outcome. And then when faced with the reality of what they are told, it is very, very difficult. And some clinics actually are lumping all mosaic embryos in with aneuploid and not even informing patients about the possibility of this middle ground.
Yeah, there's still a lot of, I think, fine points that need to be delineated in this field. So I'm very comfortable telling a patient to have a mosaic embryo transferred, but on the other hand, I don't think it's a bad idea to have NIPT or non-invasive prenatal testing for cell-free DNA, which is performed at the end of the first trimester, just for confirmation that everything is normal.
Or I guess an amniocentesis, if you're looking to specifically look at the fetus instead of the placental contribution as well. Because with the trophectoderm biopsy, we have, of course, what will become the placenta being biopsied, and with CVS, we're going to pick up the placenta as well. And I guess with cell-free DNA, I assume, is it placental or is it absolutely fetal? I guess that's I don't know.
I think it's fetal.
Straight fetal.
Yeah.
So, well, thank you. These are difficult issues that patients face, and we're just trying to do our best to help our patients through these times.
Well, hopefully we've cleared it up.